How many patients do you have on MedSync?
I kind of threw a number out, probably 3,000.
Wow.
But yeah, but
so it's MedSync. That's what you do.
That's what we do. That's
Yep.
our normal way of doing business. And by the way, I have, referring back to what a conversation we were talking about earlier, so many pharmacies do not want to do MedSync. I have pharmacies come in from all over the nation to see what we do. When I do a presentation somewhere, it piques their interest. They want to learn how to do it. And 100% of them say, Bob, you could have talked to us for 2 weeks, but until we actually see it in motion, we got a lot of moving parts here. Y'all been here, got a lot of moving parts. The store owners that come in here, they said we could have never envisioned exactly how it worked till we see what you do. Not that I have a perfect program, but it's a great start for someone who's not doing anything, and it's an eye-opener as well. So many of them have left and gone back and been extremely successful because of what they learned here. And by the way, I've got a more organized, because the demand was there before COVID, and I anticipate it coming back, a more organized process of training these patients. So, are these store owners.
Is that something you charge for, or is that just
we're going to start charging a little bit for it because it's tying my staff up for most of the time.
I think it's valid.
Day.
I mean, I think it's huge. I think, when you're kind of a leader at something, and Joe Moose is the same play, there's always people in his store trying to figure out how they do stuff. And I think it is reasonable to be compensated for that time.
Yeah, just no different than you're teaching and speaking at NCPA and that. I mean, that's your time too. But what would you say is your first, someone who wants to get started in MedSync, what's the first thing that they should do? What's your words of wisdom?
Well, the first thing I need that I always tell them is don't feel intimidated, because they just feel so overwhelmed on the beginning. And I actually was working with a peer of mine that went to PDS's sync training, which my opinion is a little different on that. But anyway, he went to that and came back, and he says, I'm going to put, so I've got a list. We're going to put 130 patients on it this first week. And I said, that's the worst thing you can do. You want to start with 2 or 3 patients your first week and get comfortable with it. And so I tell them to gradually work into it. Then as they get comfortable, they can grow more and more patients. And what happens, and I learned this from experiences, what happens, patients, store owners will go back to their store and start a sync program. And after about 4 months, and this goes back to what you said about Amina, how many do you have in sync? Well, all of them,
Right.
I can add them up, but it's all of them. They should be in a sync program. But they go back to their pharmacies and they'll start enrolling sync patients, and they'll get up to between 50 and 100 patients, and they'll call me and say, Bob, you said this was supposed to be easy. This is terrible. This is awful. It's so stressful. Well, what's happening is they've got however many hundreds and hundreds of patients. They're still doing it the same way, and then when these sync patients come up, it's a different way of doing it, and it's troublesome. So they've got to continue to move that needle to where, as Amina and I say, to where it's their normal way of doing business. Then the few patients that aren't in the sync, they're the odd guys. So you got to work through that. Back to what you asked me, Marsha, is they got to be patient. They got to work through that. They're going to have some speed bumps, but they got to work through it.
Yeah, you hear pharmacy. Oh, we tried that a couple of times. It didn't work.
Yep.
Yeah, we always tell them, till you get above 40% or so of your scripts, you're not going to see the light.
And having a bottle of scotch at night doesn't hurt either.
Yeah,
that doesn't hurt at all.
That you have to have some really good senior techs that champion the program, right? We see a lot of pharmacy owners with oh yeah, we do MedSync, and they're the only one who cares about it or drives it. It doesn't work.
No, and that's that great point. We learned the hard way. We would have one person in charge of it. It was a tech, actually, and when that tech's gone or on vacation, it blew the whole sync program. So now we really work hard at cross-training. Every one of my team members knows exactly what to do at any point. They can take a patient and roll them in sync. It's like tying your shoe for us now. So I learned that because of what you just said. One person knows it. It's not good. Not good.
We're getting a lot of communication with providers. And we are really noticing that we're very well respected. Like we kind of thought, oh, we were going to fax these off and it's going to be like sending those outcomes tips. Hey, this patient needs a statin, and you fax it 50 times and you never hear back.
I know. Yeah, everyone ignores those
but we're getting responses same day, maybe next day. And we really feel like we're part of the team.
Yeah. And not just a fax, but I've had phone calls.
Yeah.
Even just, they'll send over a new prescription for lisinopril or something.
Yeah.
So we're making some really great changes in patient outcomes, and had one patient that we got him set up with a Dexcom meter, and he loves it. And that was partially our recommendation, trying to get him to help control his diabetes. And
Change
it's just
his
so
life.
exciting.
Yeah, no, you literally
absolutely.
changed
So
his
exciting.
life. Yeah. Making a lot of inroads with the physicians then, it sounds like, as well.
I think in North Carolina that Joe and Amina have both kind of really opened.
Like, the lack of a better term, pioneered it.
Yes, they've pioneered. I mean, because there are some of our pharmacists who say they struggle to get the doctor to email them or communicate back. And I think Amina and Joe have really kind of opened up that conversation and created a great community conversational loop between the doctors and the pharmacist. So I think it's amazing and a great testimonial to get other states and other pharmacists to get off behind the bench.
Well, and also what they're doing too is they're providing value first. Like if I'm faxing you, hey, this is what I did for your patient, you can go update your chart notes, whatever you need to do, and go, hey, this is what. It's way easier to go knock on that person's door and go, hey, I'm Tory, I'm the one that sent you those faxes.
Yes, exactly.
About your patients. Man, you can have it's a much more approachable conversation than just straight up showing up. You've never met me before, but this is what we do.
Well, and not to mention that now you've created that conversation and that just engagement, and so now it's like, okay, they actually take care of my patients. It's not just going to be I send a medication and it may or may not work, and who cares? And that opens up more patients being sent to your pharmacy.
And that's a good point.
The dream.
Yeah, and you're also,
that's the end goal.
And what Madison just typed up some gold here, so I'm giving you credit for that. But it's way easier to walk up to them and go, "This is what I did do," and then tell them what you can do instead of just saying what you can do, right? So
instead of putting it the way that you.
That's a lot of this, and a lot of what's going on is we're trying to get the data that the state is collecting. They're trying to collect data. So we're not the only pharmacy working on this project. We've got like a whole network of pharmacies throughout the state, but we're trying to collect this data and say, look at what pharmacists are doing. Pay us. We are worth, these payers telling them we are worth your time and your money.
Yeah.
Yeah, it's funny. This kind of feels like that moment when you started to see hospitals decentralize pharmacy. So you used to see just pharmacy lived in the basement making IVs and sending stuff up, right?
Yep.
And then you saw a couple of the teaching hospitals start to put a remote pharmacy or a satellite pharmacy on different floors, like your ICU, your med surg. And it turns out having a pharmacist in that care team works out really well. And now you'd be hard pressed to find a hospital anywhere that doesn't have some kind of decentralized pharmacy services.
Oh yeah, almost all of them do.
Yeah, what's interesting to think about that is hospitals didn't do that because they had to, and they probably didn't even do that based on income potential. They really did that, and that's probably for some hospitals not their main way of thinking. When they move staff and people around, they're moving staff and people around for economics. So they really had to have done that, just had to have been blown away by the change in care.
Right.
Yeah, yeah, you're 100%. Just making better decisions altogether. Right. So that's interesting. What are the providers? Not to harp on this too much, but
go
what's the big draw on the providers? I'm just thinking through, if somebody's listening and I'm like, man, I'd like to get into that. And I think I have some providers in my area that would be interested in it and supplement revenue for them. What are the providers really interested in when you're going to them with a service?
And I think everybody has different motivations. And so one of the interesting things about Mississippi too is that we have independent practice for nurse practitioners. So they can own their own practices. And so that's where, because that a lot of our rural providers are nurse practitioners in their own clinics. And so that's where we've seen the most success. We do have a physician practice clinic that we're in 2 days a week. And I think, everybody's got different motivations, but I think for most it's having a really hard time. And this is what we learned from Amina, because we went and we took her classes. We did the Avant Institute with her, and we even did the class before she even had Avant Institute through PDS. And so we've been kind of planning, and we call it watering the bamboo. I think that's what Amina calls it too, of how it takes bamboo like 4 years to grow after you plant it. Like, what is this? So we've been watering our bamboo for a really long time, but we, I think it's all different. But a lot of them, I think, is that they don't have a very strong understanding of how and why they are being paid what they're being paid.
Right.
So with things like MIPS and their new quality measures. And so when Austin walks in there saying, I know all about MIPS and here's your quality metrics, I can run a report and tell you what exactly you're deficient on, and here's how we can help you get there. Oh, wow. Right. And so it's not just, hey, partner with us because we'll bring you more money. It's, hey, we have a solution for you that will fix your problems.
And but that's him working in the pharmacy. He can't do that more remote.
Yeah. So he goes physically to their clinics. Okay. So he spends 3 days a week physically in clinics doing Medicare annual wellness visits, but also he can do stuff from the pharmacy now too. And particularly with COVID, they've relaxed a lot of their rules and allowed a lot more telehealth. Okay. And so that has been really nice, honestly, to reach more patients and to reach them where they are. But yeah, so the RPM though, we even have pharmacy technicians who are helping to support that service and really advancing their role too, which is something that I'm very passionate about, is advancing the role of technicians to better support pharmacists. So
that's so for your like sync calls and things like that, they turn a little different for your RPM patients, I imagine.
Absolutely. Right? Yeah. So we have all this extra data now, right? When we're making our sync calls. And that's who's supporting our RPM and CCM program is our sync callers. So they already know these patients. They have relationships with them, and maybe their phone calls went from 2 minutes to now 20 minutes, right?
Wow.
And they have the plan of care that the physician has developed along with our pharmacist. And the technicians help support us through that plan of care, and they check in with the patients. They document stuff for us. They have algorithms that they go through that says, at this level, I escalate up to pharmacist or, whatever it may be. And so it's just been really awesome too, to watch our technicians grow. And of course, as a faculty member, I'm always interested in development of others. Sure. And so watching our technicians develop, it's just been really, really phenomenal. And seeing the relationship that they have with our patients and how that's really impacting care.
So how do you replicate that, right? If we had 20,000 pharmacies run like Bob's and Amina's and stuff like this in the country, the cost of healthcare, the way it would go down in the substantive dramatic change, I think you'd see some of the big chains stop doing pharmacy, right? It just that big of an impact. How do you do that? How do you...
I don't know. I think one of my favorite things about Bob is that he's always willing to take a chance. And I think you have to be willing to risk a little bit first to jump into something like that, right? To say, okay, I'm going to hire this pharmacist.
I'm going to hire a fairly expensive person.
I agree 100%.
To build a business.
And so you have to be willing to take a risk. And I think a lot of business owners aren't necessarily willing to do that. And so that's part of it too. But I think too, just so many, and Bob always, and I'm going to probably stealing some of his material because I know he's going to come and do a podcast with y'all soon, but he always says there's people who either want to change and don't know what to do. They don't want to change and they're just digging their heels in, or they just don't care. Right. And but I think there's a bigger majority of those people who want to change and just don't know what to do. And I think this year in particular has been even harder on that group of people because they haven't been able to go to shows and do the networking that they might have done with other folks, and just really seeing those opportunities that are out there. And so again, I think that goes back to what can schools of pharmacy do to help them innovate and to show them.
So talking about relationships, and that, and I don't know if this is the direction you want to go with this, but so our local health department, which, to give you a little backstory, right before the pandemic hit in January of 2020, we had a meeting because CPSN Missouri was rolling out with trying to connect with, Tripp, Logan, in Southeast Missouri had just found a possibility of getting a HRSA grant, was working with pharmacies, community health workers and health departments and helping them screen patients for various conditions.
He's such an animal.
He is. He's amazing. So what I said was, Tripp, I want to have a meeting with my local health department. We just got a new director. And he's like, let's do it. And so he wasn't able to be on the call, but I got Michaela Newell, our director, on. I think she came down. And we had a meeting with them. And when we walked in, I said, I've been hearing weird things about this coronavirus. I said, I wonder what's going to happen with this. He goes, who knows? And before we know it, we had our meeting and we were talking about collaborating together. First meeting we ever had. Lord knows that we would be collaborating together in different ways.
Yeah.
So, we have, before we even got vaccine, they started getting some, and we actually sent some of our technicians and our pharmacists to help them do their clinics. And he's like, so you guys having trouble getting vaccine? And we were, initially it was just kind of all confusing. I was doing my share of yelling and complaining to the state, but long story short is he said, why don't I just order you some in? I'll allocate it to you. And guess what? We got vaccine the next week.
Wow.
And it wasn't because we went and volunteered. It was because we had that relationship.
Yep.
And so to bring it a little bit further, and I don't know all the ins and outs, but he said, I have 2 nurses and they both quit on me last week. And I can't give second doses until I get these new nurses. And then he's like, can you help me? I said, sure. Tell me what you need me to do.
Yes. Let me figure it out.
So we have helped them with a couple of second dose clinics. And he's like, I'm not going to schedule any more first dose clinics. So any vaccine I get, I'm going to have to send to you. And I'm like, okay, that's fine. And now we have more vaccine that, that's why we're trying to do all these relationship things and working on trying to get these things through. I have more work ahead of me than what I probably realized, but making these connections is really key. Now, I will tell you, I'm going to take this, and you can stop me because I get to rambling, but I will take this the next level and say, I'm still working on that original conversation that I had back in last January. And I'm proving to our community and to our health department and to our local hospital that we want to work with people and we're a valuable resource in this community. And there's things that we can do very nimbly, just in a very, I don't know, is nimbly a word?
It is now.
Very quickly. It is now.
Just made it one. Trademark it.
Thank you. Yeah. Yeah. Put that on Wikipedia or whatever it is.
Yeah, we'll put it in the Urban Dictionary.
Yeah. So I think us being nimble and seeing that we can fit in some of these places, COVID has created so many opportunities for independent pharmacies. And you guys have seen that, and independent pharmacies seeing that. And if we're not taking advantage of that, then, I don't mean in a bad way. I mean, just stepping up and saying, hey, here we are. I'm not, I know the big chains are taking people's personal information and marketing it in other ways. I'm not doing that. But I'm stepping out here. I've got 3 or 4 people waiting right outside my door right now after their vaccine. So, and I'm just going out and saying hi. And if you need anything, let me know.
You're absolutely so great marketing to those.
They're getting one of these. They're getting one of these right? With everything.
Right. Yeah, but you're marketing those people not by calling them later, send them something in the mail. You're marketing them by being efficient and being friendly and all those things that they're not going to see in other places.
Or
it's like the best kind of marketing, which is like you get to create an experience for them. And
you're right.
And one they get really impressed by.
So I think for all new pharmacies that open or ones that we convert to Pioneer, we should send them a T-shirt that says "No relationships, no future."
That's so true, though. Like Tripp said the same thing, and
we hear it again and again and again.
I know everyone in my community, and maybe not everyone, but like your health department, your public health department, whatever that is in your vicinity,
you could also say
region.
No, yes, no future. And seems kind of
literally weird. The last one we just did was like it's just about being available sometimes and just saying yes when you're not sure.
Because those guys that say, yeah, Tim's going to figure it out. I got a problem. Tim's going to figure it out. And
well, unfortunately, my wife said, "What are you working on
saying
now?"
Yes.
Yeah. I think there's a movie that says "The Yes Man" or something like that or whatever. I unfortunately I don't say no very often, and that does get me into trouble. So I do have people in the store, and of course I do need to realize I need to balance my personal life with my professional life. But when you're an independent pharmacy, you are married to this, and my wife says my pharmacy is my mistress. I say that lightheartedly, but sometimes she gets really, really irritated at me.
So I like the M word, but the pharmacy is your mission.
Yeah.
True. There you go. I need to tell her that.
Is probably
there you go. Now.
It is probably clearer. And what an amazing mission that is, right? Yeah. If you were put here to care for people, is there any better place to do that than a pharmacy in a small town? So,
I think God. I'm a Christian, and I think God puts things in front of people, and you need to then figure out how to do it. But God puts a brain in my head to figure out, okay, that is a good thing, and I need to do that. I need to do this for my community or do this for my family. And I do feel that we have a big mission with COVID and everything else, but I do want to carry that on. And I know many independent pharmacists are doing that. And when I say take advantage of a situation, I think it's important for us to step up. This is an opportunity. Yeah. It's not a time where people should feel burdened, although it sometimes can be very time consuming. You're making calls and trying to.
Well, the initial setup is always a burden and always stressful. But then once you get that ball rolling, then it's just, okay, it's another knob I'm turning over here.
You're right. I compare it to building a road. When you see those big mountains. So down south of here in McDonald County into northwest Arkansas, where the Walmart country is, they're clearing some mountains and putting new interstate in there. And, when you first look at it, you're like, okay, they're going to put a road through there. Yeah. And so now they're in the process of knocking those mountains down. There's a big hole, and they've got their gravel down, and they're getting ready to lay pavement. And then, so that's where we're at. I think we've knocked the mountains down, and we're plowing through, smoothing things out. And we're going to put our asphalt down, put the lines on, put some signs up, and that's going to be our freeway for the future. So I don't know. That's what I tell my staff. They look at me like I'm crazy, but
have any of
I look at Jeff that way a lot.
Yeah, he does.
Yeah, we both do. It's like you want me to do what?
I like me like that a lot too.
What are you looking for? Like when you have that, let's go back to kind of just the people you put in place. What kind of staff are you looking at when you're kind of building these models? And you talk about, you had somebody that was basically had the volume to be successful, what you were talking about, but they just seems like didn't have the model. You guys came in and cool, you guys going bankrupt. We come in, we put our model in place and it works. Is it, what kind of staff are you looking for? What's the staffing model look like a little bit?
Yeah. So, I really like the partner model. I have some stores that have managers and I own them outright, but I do have, most of them are a partner. And that kind of goes back to Bill Osborne. And if you got some skin in the game and you're at that store, you're going to run it like every dollar's yours. And so, that model works the best. And, but these stores like the one we were just talking about, they're not run very cleanly. And pharmacy is an industry that is like no other. And when you sit and have a beer and explain it to somebody, like for instance, you go to the grocery store, you buy a candy bar, you pay $1.50, you hand the lady $1.50, she puts it in the till, they put it in the bank tomorrow.
Yeah.
Right. And the only way that store loses money is if they don't price it right or someone steals it. Right. Mm-hmm. So here in our industry, we're pressing, F7 or F12 or whatever button that is to rifle that claim off. And if you have an obsolete NDC, you got a package size wrong. Boom, you could lose $50 in 2 seconds. You could lose $100 in 2 seconds.
Yeah.
You submit a flu shot without an admin fee. The pharmacist forgets, or who's ever billing, the technician, $20 lit on fire, right? And you're not going back and looking at those. You're always going forward. So what industry can lose so much money on a simple transaction by just a minor little error? That's us.
That's true.
And
super
true.
Yeah.
And so we have so much money wasted for ourselves in our industry by just not, basically dotting your I's and crossing your T's and watching the pennies. I had an old saying, and I can't remember who told it to me, but you watch the pennies and the dollars will take care of themselves. And so we get into these stores and we just start plugging all the leaky money holes, whether it's, double internet bills, extra phone lines. I mean, I don't know how many stores I've grabbed the phone bill and they got 6 phone lines they haven't used in 10 years.
Oh, wow.
You know, it's $30 a line. I mean, right? You know, it adds up.
Yeah.
So you start plugging these holes, and pretty soon, you know, you just save $2,000 a year, or you just save $5,000 a year. You just saved another $5,000. You know, next thing you know, you got 40, 50 grand you've saved of just waste. And it's not necessarily, you know, dispensing the prescription, but it could be how you're buying your labels and your vials and credit card processing. You know, I've worked with you guys on some credit card processing stuff, you know, to help make it more advantage to on the fee side for the end user. So all those little things, we start plugging that, and boom, that store with that volume is now super profitable when it wasn't. And it's more of just the things I've learned over the years and the process we put together. And it's fun. I mean, it's fun digging into a new store. You know, I'm doing it right now at a big volume store. I mean, you know, 3,500 scripts a week, and it's so profitable. And if you did nothing, it'd be a great store. But now you start plugging those holes, and those holes typically are bigger holes.
Oh yeah, no doubt.
Yeah, well, because it's exponential with the volume. So you plug that big hole, then you start working on the smalls. Pretty soon, it's eye-opening. I mean, it really is.
So clearly, you have metrics. You kind of have a. It sounds like I'm hearing a lot of stuff around data you're looking at. You guys are heavy. It sounds like into data analytics. Then, if you're talking like package size, making sure you have an admin fee for vaccinations and things like that. What tools or what tools that are out there that you guys use, or maybe it's all internal to identify those things?
Yeah, some of it's internal. We have a guy, and I'll kind of tell you the whole story on it. And but there are tools out there now, and I'd say probably in the last 3 years, there's more out there for pharmacies than not. With different, PDS had something like that, and FDS, and some different ones of those companies have data analytic type models. I think some of the wholesalers do as well. But it's one of those things where you're going to pay for a fee for service, then you don't use it, right? Right. So how many fee for services do we go to these conventions and we're like, God, that's awesome. I'm going to sign up for that. That's $299. Oh, I'm going to sign up for that. That's $199. Oh, that was even better. That's a $499er. Next thing you know, you're $3 or $4 grand a month into all these fee for service platforms. And if you're not using them and not getting an ROI, you're absolutely lighting money on fire. So that drove me nuts, because it's kind of like, I got smart people. I mean, I've always said I'm only as good as the people that I surround myself with. And some of my partners, or all of my partners, are fantastic, but some are really, really super smart. And so when I bought a store, I had a pharmacist. It was the son of the guy we bought out, and a super analytical type of a guy. Really into the systems of the body, really into the clinical side, but not like an outgoing kind of guy. I'm like, hey, his name's Ben. I said, hey, Ben, would you like to speak? No, I don't want to speak.
No, that's not my thing.
So I was driving home from visiting that store, and I got about halfway home. I think that store's about 2.5 hours away. Actually, where I live, and everything's 2 hours away.
That's like Dallas here. Everything's an hour away. Everything's an hour away, no matter where you go.
So I got about halfway home, and the light bulb came on. I was like, he's got some super talents, and he's a pharmacist. And I've always been wanting. We were dabbling in the data analytics with our buying group. I'd helped develop a product that we offered to the buying group pharmacies. And I said, you know what? We've got enough locations. I can afford to hire a pharmacist to do this. And Ben has taken it and run. And run. And we now analyze all our data every night. We make sure that the package sizes are right, the NDCs are right, that we're not missing any admin fees on flu shots or shingle shots or anything like that. If they do, or let's say a brand went generic and you ran the brand and it's a new enough one where the staff maybe forgot it's generic. They're not going to pay it at a brand rate. They're going to pay at the generic rate. So you lose $100 there, $150 there, whatever. And some of those he catches in real time. He's got some metrics that he's built in and he's watching. I always say it's kind of like the guy in the Wizard of Oz. He's behind the great curtain and pumping all the different levers.
Right, he's pulling on these levers.
Yeah, getting the data out. And anyways, it's really helped us, guys. I mean, he sends a report to the stores. and they fix those claims every day, the next day. Wow. And we also in that report that goes to the stores is our late refill people. And so we have a system where the technicians will call and say, hey, Mrs. Jones, your prescription it looks like it's a little bit past due. Would you like a refill? And I mean, this is simple stuff. People are doing this, so we're not like, this isn't recreating anything that most people aren't doing. But I know, Mrs. Jones, I see you got 4 or 5 other things that are coming up here this week. Would you like those? Oh, absolutely. And you'd be surprised the volume we pick up. But that is more than the volume, because now we've made her compliant, right?
Oh yeah.
And so we take 10 patients non-compliant, compliant. Our DIR fee goes down. Our scores go up, and we're saving money that we don't see and feel. And that's when the whole picture becomes rosy, for pharmacies, when you're able to collect and save that money you're not seeing by doing, I call it the snowball. If you can do it right in the beginning, it doesn't snowball into a big giant ball and hit you in the face at the bottom of the hills.
Right.
So yeah, we're heavy into data, and Ben has done a fantastic job for me.
That's a really cool thing about pharmacy is the people that are involved in this industry. I mean, you really do make lifetime friendships. Just very collaborative thinkers. Absolutely, patient care is first and foremost on their minds, and how to make it better for the patient. I'm just excited that they allowed me to stay in the profession, even though I'm not a pharmacist. They've embraced me as a thinker, a forward thinker, and a fixer of problems. And so happy to be here.
So from community care, you went to PPOK, is that right?
I did. And, that's probably one of the funniest stories of my career. Lonnie Wilson, long time mentor in the pharmacy profession.
What a great guy.
I would negotiate contracts on opposite sides, right?
Oh,
As
okay.
the HMO, I needed a pharmacy network, and Lonnie, representing independent pharmacy in Oklahoma. So I spent years negotiating contracts with Lonnie Wilson against each other. And Medicare Part D, that whole program, the way it's built, the complexities, it can really take a lot out of a person. And so I was looking for something different. I'd had enough of the managed care system, the challenges, the difficulties, where things were headed. And so literally one day I called Lonnie up and I said, Lonnie, are you busy? And he said, well, I'm actually driving back from a board meeting. He was on some interstate in Wisconsin, I believe. Go, Pat, go. And so he was driving down the highway, and I said, well, what do you think about maybe me coming to work for you? And he, to his credit, he was always so very professional. He said, that's an interesting idea. Let me think about it. And I'll tell you what, when I get back from this trip, I'll call you and we'll explore it. And the way he told the story was he hung up the phone with me, turned and looked at Bob Greenwood, who was driving, and said, I think hell just froze over.
I was about to say, was that like the beginning of a, not just no, but a hell no, but politely said?
Well, I think the idea intrigued him so much that, and I'm very thankful that it did. He literally hired me in. He said, I don't know what you're going to do, but let's bring you over to PPOK and see what happens. And that was January of 2010.
Wow.
And we went from 360 roughly pharmacies, mostly in Oklahoma, to when I left June 30th to take over this position here at Align, we had 2,200 stores.
Wow.
And so it developed out, and Lonnie, to his credit, he let me do what I do best, look for problems and find solutions and create programs and services to improve the lives of the pharmacists and clients that we take care of. And so,
all right. So PPOK had a PSAO,
mm-hmm.
and then
yes.
they split that part off and joined with Arete. Is that how you said?
Arete, correct? Arete.
And then they put you in charge of that when they did that. Is that?
They asked me to lead the organization, what is now known as AlignRx.
Okay.
And so we are right now going through the process of evaluating the programs that PPOK had to offer and evaluating the programs that RTA had to offer and finding those synergies and migrating, consolidating processes. And I think the community pharmacies are going to be very happy with the end result of what we're going to be able to provide to them very, very shortly. So
okay, and so how new is that? How new is this new AlignRx?
Yeah,
I became the first AlignRx employee on July 1st
of this year.
Of this year.
Oh wow, okay.
And then August 1st, we actually did the signing of the closing. So it became official August 1st. At pharmacies from both entities were assigned into Align, and we went through the process of collaborating with the PBMs and getting those contracts assigned in. And so we have just under 4,500 pharmacies right out of the gate. We're the largest PSAO in 8 states, second largest PSAO in 12 additional states. So right out of the gate, we've got a wonderful footprint and a great group of pharmacy owners to represent and serve. And I feel very fortunate that we get to do the coolest thing possible, which is provide those products and services so that pharmacists can do what they do best. And community pharmacy, I've never been more proud than what we have seen come through this pandemic, and the fact that community pharmacists are the absolute heroes frontline. And I feel very, very blessed to have been part of the administrative support to all of that.
Let's step back like 3 breaths. When you said the program for training technicians is rolling out this month, where is it rolling out, and what kind of training does it look like? What does it look like?
Yeah. So thanks for asking that. The experience we've had with community health workers. So we trained our first technician as a community health worker about almost 4 years ago, I guess. And each state, the curriculum's a little bit different in what's required, but I can tell you the journey in Missouri has been get them trained, get standardized curriculum, get that recognized by the state, and then see what you can do with that from the pharmacy and the outreach worker standpoint. So that we'll just put all that process aside and just assume that either states recognize a community health worker or they're interested in recognizing a community health worker. So what we did was we were approached after some success that we had in public health arrangements and so on in the state of Missouri to help create a curriculum specifically for pharmacy technicians.
Okay.
Because what we're finding is, I was just at the PQA annual meeting last week, and everything's social determinants of health now.
Yeah.
Really?
Yeah, I guess we were.
Yeah. Yeah. So we were there, and it's funny. Everything's SDOH, social determinants of health, the last mile care, local. But what happens is a lot of times, in my experience, those that are in charge of providing that are a lot of times not local. And the people that need to be engaged, that are the highest cost, most at risk, those people are the ones without cell phone minutes or broadband. Right. Mm-hmm. So like, how do you've got to have somebody local. So having a sustainable place in a community like a pharmacy to have an SDOH expert like a community health worker just makes sense in today's environment. Our state saw that. So they commissioned us to help build a curriculum based on the framework of like some curriculum that already existed. Like, here are minimum standards for curriculum.
Okay.
So Bianca Daisy Bell, our clinical director and for our company, for our pharmacies, helped, and she used to be in academia. And so she helped write this curriculum, got it approved in the state of Missouri. And then we took that curriculum and we commissioned CE Impact to help us make that sustainable. Because one of the things that we found out was this curriculum's great, but if it's at a community college and that's, the classes from 3 to 6 on Tuesdays, a technician ain't gonna be able to go do that. So we had to think outside the box and come up with something that was longitudinal. The hours were maybe work at your own pace, cohort based, but that technicians could do. And so our first cohort is being onboarded right now in May. We're gonna have 3 classes this year, and we're scaling this as fast as we can because the need's there. I've talked to by the end of July, I'll have talked to 6 different states, I think,
Really?
Whether it's their state association, pharmacy association, whether that's their public health department, whoever that is, about this endeavor, because it's a solution that's pretty simple. Like, okay, so let's empower our technicians to focus on in-need patients. That's all right. Let's come up with enrichment opportunities for our current staff that makes their job more rewarding. Not a big downside either.
Right.
And maybe it helps provide some, you're the target of last mile care for underserved populations. I mean, that's still all, that gives you the good warm feeling all around.
Right. Yeah. And that's one of the things, through a lot of the podcasts we talked about, it's really been focused on, pharmacy just absolutely hitting a home run for public health. And, we're all that, if we weren't into public health, we probably wouldn't have been pharmacists in the first place. And so, this seems like a really nice natural evolution of, all right, pharmacy's proven that public health has to be a central tenet of what we do. And like most good programs, they're successful because you have really good technicians doing a lot of the groundwork. So I really like the idea of it. I have to see if Texas is doing anything like that at all.
It's also resonating. And again, I go back to these technicians are typically doing this work anyway. Right. The good ones are. Like our crew's they've been helping people through tough situations and getting transit and housing authority and Meals on Wheels for years.
Yeah.
Medication, if they can't get it, if it's too expensive, finding ways to get medication. We just consider that like normal practice, but that is hugely important, especially if you start quantifying like how much money is saved. We showed in our first community health worker project, we showed that over 100 patients, we saved an average of $70 out of pocket per patient per month. That's not total cost of care. That's $70, and that's only in patients that determined that they could afford their medicine afterwards. And so that $70 was out of pocket per month that we saved people by engaging a community health worker and a pharmacist, their healthcare provider, to really triage the situation and make sure that it was affordable.
So Lisa has a consulting group. Right. And what the name of that is? DiversifyRx.
Yeah. DiversifyRx is the name of the company.
Yep.
And everything we do is under that, but we have a membership, which is Pharmacy Badass University, which is for pharmacy owners that, want to make changes in their business. They want to improve their profitability. So we have a membership that people can join that's a paid membership. I always flip people, go consume all of our free resources. You mentioned the podcast, but we put out blogs, weekly emails, we do the YouTube videos, because we really are just trying to help pharmacy owners in any way, shape, or form.
Yes, weekly awesomeness. I get those.
Yes.
And I read them, and I love them.
Do you feel more awesome because of it?
I do. Yeah. I really do.
I think you are. I've seen a change. I've seen the effect. But keep going.
It's all about the energy. We got to transfer the energy, and you can even transfer it in an email. That's for sure.
This I think is important because one of the things. Oh my. Lisa used to work for PDS. She was in marketing PDS, and I think one of the things I saw over time, and probably once PDS was bought by private equity, and I feel like I don't have any facts on this, but I feel like the new bosses started saying, you're giving away too much stuff for free. People aren't signing up for memberships. You're giving away stuff too much for free. And I went to Lisa's show that she
this
had
last February.
No, but I went to the one before in Dallas.
Okay.
We weren't there the whole time. We went in there just to kind of shake some hands and kiss some babies and help them pack up. But Mickey Fine was talking to him, and he was like, Lisa has a bunch of does. She helps me so much. I feel obligated to buy the membership. Right?
That's Gittimer. People buy from people they like.
Well, it's a value first.
It is value first marketing. Yes.
And it's saying that, hey, this is a trustworthy group.
Mm-hmm.
If I provide them enough value, they're going to support me. And I think you're seeing that. I think that's super. So I wanted to, when you plug that made me think about what Mickey said. Go ahead.
Yeah. Well, and the way that I look at it is I always want to be behind on the, exchange of brownie points between me and a pharmacy owner. Like, I always want them to have gotten more from me than I have gotten from them. I always want to be trailing. And so I have this innate need, and it comes from actually like deep, like insecurities. That's like, there's always double-edged swords to everything, but I have this deep innate need to be useful to people and to be valued. And the way that I do that is I overgive, and I love sharing. And so it's like, I always want people to feel like they love me and they value me, and I'm the most valuable thing in pharmacy because I've given them so much and they've had to give so little in return. Like that's like my motto.
If you enjoyed today's episode, please like, subscribe, and follow us wherever you get your podcast.
Give us a 5-star rating on Apple Podcasts to help us reach more pharmacy professionals like you.